on with the next talk that features Dr. Ambuj Roy, Additional Professor of Cardiology at All India Institute of Medical Sciences in New Delhi. Dr. Roy joins us this afternoon to speak on anti-hypertensive treatment strategies post-guidelines era.
Good afternoon, everybody. And at the outset, I'd like to thank the organizers for inviting me to speak at this important forum. The topic given to me today is anti-hypertensive strategies after the latest guidelines. And as this conference breaks many glass ceilings, I think it's very important to look beyond the usual practice of blood pressure management, that is the guidelines. And I shall basically speak on the recent guidelines which have come, how different they are, but more importantly, how we should look beyond the guidelines and move from guidelines to implementation of these guidelines in the population so that the maximum benefit of blood pressure reduction is achieved. So this is kind of the timeline which is there. The JNC7 came in 2003, after which we've had a flourish of trials, evidences in blood pressure medicine. We've had the guidelines. 2013 we had the ESC guideline, and now recently this year we had three guidelines, the JNC8, which came after a long time, called JNC late also, on the International Society of Hypertension guidelines. And of course we had the ADA 2013 guidelines also, which talked about diabetes and hypertension management. I'll stress not too much on this, but the slide broadly shows what has been the stress of these guidelines. The JNC8 unfortunately has gone back a little and just looked at RCTs, the random controlled trials. They've ignored a lot of important observational studies, which are very important to assess and take forward blood pressure management. There are other guidelines who have actually looked beyond RCTs and have also looked at wider research papers. This is a very busy slide, but it really sums up the differences between the guidelines, which I shall deal with individually. So what are the key differences? One is the BP goal. So the JNC8 created a lot of flutter among the blood pressure management physicians by changing the guidelines for the targets for blood pressure in elderly, and it shifted the goal from 140 to 150. And however, it did say that a good amount of the members of the committee actually went on to produce a paper in Annals which contested this guideline, and I would rather agree with them that there is a wealth of evidence and there has been a lot of benefits of sticking to targets of 140, 90. And this we can see from a survey which was done in about 3,000 urban and 2,500 rural population in the National Capital Region, which we just completed, and it was presented at the ESC Congress last year. And it shows the quite poor awareness among the population. It's to the tune of only 50% of people are aware that they are hypertension when you go and measure blood pressure in the community. Of this, about 3/4 are on treatment. But if you see the overall control rates in urban Delhi, which is the capital of India, where you expect good medical care, was just in the between 10 and 15%. So that how poor the control rates in the population is. When we go to rural NCR, which was Ballabgarh, which is affiliated to our the community of medicine, is the PHC, and the community village affiliated to it. And if you see there, it's abysmal. The overall control rates in the population is in single digits. So we may keep talking about finer things in the guidelines, but when you go out there among the people, you realize that it's not working. I mean, it's extremely poor, and that's why high blood pressure is one of the leading cause of death internationally. It is responsible for 45% of ischemic heart disease deaths, and it's responsible for more than 50% of stroke deaths universally. So obviously the disease burden is huge, and we need to think alternatively and go beyond the guidelines for managing blood pressure. And this has to be done at two levels, at the that it be provided at the governmental levels, like the tuberculosis program, for example, where the governmental agency needs to be involved in blood pressure management, CVD risk management, because that's now the leading cause of mortality in India. And we need to improve our treatment strategies as clinicians. We need to improve our treatment strategies. And one of these strategies is to more and more be shifting towards a combination therapy approach rather than the stepped-up care approach, which has been there for years together. And it's been clearly shown that if you are on 2 half doses of drugs, you are likely to have 5 times better effect of blood pressure rather than if you double dose of blood pressure which you were taking earlier. So adding a half dose of a second drug gives you 5 times better control as compared to doubling the drug half dose which you're taking. And the benefits of vascular mortality. And this is again from the same study we've seen, which we've done a cross-sectional survey of National Capital Region twice. One was in the early 90s and one now. And within 2 decades, there has been a significant shift in the systolic and the diastolic blood pressure of the community. And this has a huge impact in terms of CVD mortality, morbidity, and all endpoints related to blood pressure.
I'm sorry for the interruption, Dr. Roy.
Yeah, just last 2 slides. So at the population level, we need to talk about salt reduction. We need to increase things which are known to reduce blood pressure, like physical activity, better diet, check obesity, and increase physical activity, and moderate alcohol use. This is the last slide. I would just say this shows what a 2% population-wide reduction in diastolic blood pressure could do. It could reduce 100 million deaths in Asia and 300,000 by just reducing 2% of population-wide diastolic blood pressure. So we need to combine the individual and the population events. There was some increase in hypertension in the intensive treatment arm. But if you see overall, the stroke rates were reduced. So clearly, when you reduce blood pressure, you give protection from stroke. Although it didn't show mortality benefits as it was expected to, but there were some shortcomings with the trial, but it surely didn't increase cerebrovascular insufficiency as you seem to be suggesting.
Now the studies are on where they're going to see whether if you go down to say 130, 80 and even say 130, 75, even during that time, is it beneficial? Because if it is found to be beneficial, obviously the lower pressures would be modified.
Yeah, yes, that's right. So observational studies seem to suggest that. The only RCT which we have is a CORD BP, which showed benefit in strokes, but not in the overall endpoints of cardiovascular disease. But yes, we need more studies like that to kind of really pin it down.
It is concluded that 140 by 80 is sufficient, but if blood pressure goes to 130 by 80 or 75, if the patient can tolerate, in special population who are prone to stroke, they will be benefited.
Then the other thing in hypertension is you mentioned that instead of increasing the dose of ACE inhibitor, it is better to add a drug. But on the other side, we say if the dose of ACE inhibitor or ARB is low, the protective effect is not there. So obviously, when we use the drugs which are which have a very strong role in prevention, isn't it better to increase the drug dose to maximum and then add the second drug? Because most of the patients whom we are going to give combination drugs would be generally moderate to severe hypertension.
Yeah, so my point is, first of all, about controlling blood pressure, right? So if the point I was trying to say is that if you're not controlled with, say, half dose of ACE inhibitor, so the choice is between going, I think it's a class effect so much, it's more of a blood pressure control effect, which is more important.
Actually, guidelines say if the blood pressure is 20 by 10 millimeter of mercury higher, then your goal, you need 2 drugs.
And
which, yes, and which 2 drugs, that depends on the comorbidities. Yes. And these different trials, they have shown that the ACE inhibitors and this amlodipine group of drug are better then
Especially
ACE
if you're
inhibitors are diuretic.
younger,
Yes,
ACE inhibitors are better.
Thank you. Thank you very much, Mr. Chairman. We have run out of time for the discussion on this session. Thank you, Dr. Roy. We move on now to the next oration. Before that, we have the presentation of award for Dr. Ambuj Roy. May I request the chairpersons to kindly step forward and present it to Dr. Roy. Dr. Viveka Kumar would be joining him. Yeah.